this image is super high yield for you. Now, which cells in the alveoli will try to consume the red blood cells that recently extravasated through those vessels that were under chronically high levels of hydrostatic pressure? Well, the cells in the alveoli that munch on these red blood cells are called alveolar macrophages. So these alveolar macrophages eat red blood cells, and just like macrophages anywhere, they break down hemoglobin into its components, which are globin, protoporphyrin, and iron. Remember, iron sits at the middle of that protoporphyrin ring, and what happens is that the breakdown products accumulate and cause this rusty coloration to the phagocytic cells. We call this hemosiderin accumulation. That's a pretty cool pathologic sign of pulmonary congestion that occurs chronically in people with heart failure or backward failure. But we're not going to be taking pieces of our patient's lungs if we suspect pulmonary congestion. Even though this is fair game on your step one, you're never going to see this clinically. When you never see things clinically, and you have to learn them at some point, and then you become a test question writer, what are you going to make people answer questions about? Stuff that you never see, but you had to remember and you have to memorize. You have to know these hemosiderin-like stained macrophages, which are called heart failure cells. Now, what are some physical symptoms your patient will report to you when they initially present? Because that is what's important. So are these heart failure cells. So, in the combination of the two, let's think about them. They'll say, hey doc, I'm having trouble sleeping at night because sometimes when I lay down, I get short of breath, or when I finally do fall asleep, I will wake up feeling very short of breath. The two doctor words for these are orthopnea and paroxysmal nocturnal dyspnea. So, both are related to the decrease in venous pressure when you're laying flat in bed. So during the day, when you're on your feet, venous hydrostatic pressure is high in the vessels of the lower extremities due to the gravitational force preventing all of the blood in your lower extremity from returning to the right side of the heart. So you have a fluid shift from your vessels into the interstitium of your legs. But when you lay down at night and you prop your feet up on your favorite pillow, you elevate your feet, eliminating that component of gravity, which decreases some of the venous hydrostatic pressure because now the fluid can return from the interstitium into the vessel. We reabsorb that fluid. There's no more gravity limiting venous return, and that venous return goes to the right side of the heart. All of a sudden, that fluid from the third space, the interstitium, causes increased venous return to the right side of the heart, and this increased blood volume is delivered to the pulmonary vasculature. This increases the pressure within those vessels of the lungs, and fluid that was previously third spacing into the interstitium of our lower extremity is now going to third space into our alveoli. This increases the pressure within the pulmonary vasculature, which is the main problem. Now, if this occurs immediately, so whenever you put your feet up, you get an immediate problem with breathing of shortness of breath, that's called orthopnea. So the reason it's called orthopnea is that ortho is Greek for straight. So when you lay straight on your back, you get the sensation of breathlessness, which is pnea, or dyspnea is the Greek word for breath. Now, paroxysmal nocturnal dyspnea is the same exact concept, except that it is not immediate from the moment you lay down. So paroxysmal is a word that's super awesome because it means severe fit of a disease, coming randomly, paroxysmally, right? Nocturnal means night, and dyspnea means sensation of being short of breath. Remember, apnea means breath, and then dys means dysfunctional, right? So, combine all these together, and it tells you that your patient is having transudation of fluid into his or her alveoli after being supine or straight on their back for a long period of time. So, if it's sudden, it's orthopnea, and if it occurs in the middle of the night after laying down for a period of time, it's paroxysmal nocturnal dyspnea, or PND. The physiology is still the same, one's more acute than the other. Now, what is that underlying problem? Is that increased pulmonary hydrostatic pressure causes transudation of fluid into the alveoli, period. Can alveoli participate in oxygen and carbon dioxide exchange if there's fluid inside of the air spaces? No, of course not. Now, the main concern that we have about the persistently high hydrostatic pressure in the pulmonary vasculature is not the pulmonary edema, even though that can freak your patients out because they feel short of breath. You just give them some furosemide and help them out. What we are worried about is the chronic hypoxia that pulmonary edema can contribute. We need to be worried about the permanent effects that occur with pulmonary vasculature responses. For example, hypoxic vasoconstriction and remodeling, and what that will do to the right side of the heart that tries to pump into these remodeled pulmonary vessels. This is the main concern for us. We discuss pulmonary hypertension in the setting of a congenital heart defect and the progression of a left to right shunt reversing what we called Eisenmenger syndrome. Now, it never hurts to review incredibly high yield things like pulmonary hypertension, especially considering that pulmonary hypertension can present in a 2-year-old with a congenital heart disease or an 80-year-old with congestive heart failure. Remember that when there is increased volume of blood in the vasculature of the lungs, vessels are recruited and vasodilatation occurs to help alleviate potentially significant increases in pressure. Over time, though, we max this out. There will be so much increased flow and backup of pressure in the pulmonary vasculature that we accumulate the effects of continual shear forces. This leads to endothelial cell damage, and endothelial cell damage leads to release of factors that are stored within them and decreased production of factors that they are supposed to make when they are normally functioning. It releases endothelin-1, which is a very potent vasoconstrictor, and we lose the production of very important things like nitric oxide. Now, what else does endothelin-1 do? Endothelin-1 also causes vascular smooth muscle cell chemotaxis. Where are endothelial cells lining? They're in the intima, right? Where are vascular smooth muscle cells going to chemotax or move to if they sense a very highly attractive molecule of endothelin-1 in the intima? They're going to go to the intima, and that is not where they're usually found. They're usually found in the media. So, in addition to vascular smooth muscle chemotaxis and vasoconstriction, you're going to have proliferation of vascular smooth muscle within the place that they normally reside anyways, which is the media. So all of these things are bad. Vasoconstriction obliterates our lumen. Vascular smooth muscle proliferation obliterates our lumen. Loss of nitric oxide leads to vasoconstriction, further obliterating the diameter of our lumen. So in your mind, endothelial damage from shear forces and volume overload should lead to release of endothelin-1, which causes vasoconstriction and vascular smooth muscle cell chemotaxis and proliferation in the wrong places. So, increased hydrostatic pressure equals shear forces equals endothelial cell damage equals vasoconstriction, vascular smooth muscle chemotaxis to the intima, and proliferation within the media, leading to a very tiny lumen for the pulmonary vessel that we were talking about. In addition to all the things that occur from endothelin-1 release and decreased nitric oxide production, we can expose von Willebrand factor and cause formation of tiny thrombi in the small vessels of the vascular bed in the lungs. Now, all of these come together to do one terrible thing, which is what? They increase the pulmonary pressure, right? And that is how we shift from left-sided to right-sided heart failure. How does this lead to right-sided heart failure? Well, the right side of the heart is accustomed to pumping into a highly rich parallel network of pulmonary vessels. If we start knocking some of these off with tiny thrombi from exposing von Willebrand factor, and then we start decreasing the caliber of these vessels from endothelin-1 mediated vasoconstriction and vascular smooth muscle cell proliferation and growth within the intima, then we start increasing the resistance incredibly high because we have decreased the diameter of our lumen for these pulmonary vessels. So that means we have lost this incredibly low resistance circuit in the lungs. So after the fibrosis, the vasoconstriction, and the microinfarctions of our pulmonary vessels, we have knocked out some of these vessels and greatly decreased the radius of the ones that survived. The right side of the heart is spoiled. It's not used to pumping into such a highly resistant circuit. What is it going to do? It's now pumping against a higher afterload. It's going to do the exact same thing the left ventricle does when it is exposed to hypertension. It's going to undergo compensatory concentric hypertrophy because it is now going to be pumping against a very high afterload. And this is how left-sided heart failure leads to right-sided heart failure. Do not let anyone confuse you. This is not cor pulmonale. This is not that. What is cor pulmonale? Cor pulmonale is only used when intrinsic lung disease. So if we have our left side of the heart, then you have your lungs, left-sided failure leading to right-sided heart failure is not cor pulmonale. It has to be something intrinsic to the lungs leading to a high afterload due to obliteration of pulmonary vessels that leads to right-sided compensatory concentric hypertrophy that leads to right-sided heart failure. That is cor pulmonale. So the pathophysiology behind cor pulmonale, again, an intrinsic lung problem, is due to decreased oxygen, either delivery or diffusion, right? And whenever there's low oxygen within the lungs, it leads to hypoxic vasoconstriction, right? And just like we saw how vasoconstriction led to right-sided heart failure in the situation from left-sided heart failure causing pulmonary congestion and pulmonary hypertension, this intrinsic cor pulmonale process will lead to hypoxic vasoconstriction, causing an increased afterload for the right side of the heart. The increased pressure in the pulmonary vasculature causes the right side to add sarcomeres in parallel. Remember, parallel is concentric. And individual myocytes hypertrophy to increase contractile force. The problem is that eventually you will thicken the right-sided heart wall and it will become non-compliant. Here we go again. Except the right side of the heart, super thick wall, is non-compliant. The venous system is trying to drain into the right side of the heart. The right ventricle is super thick. It's going to back up its volume and pressure from the right ventricle to the right atrium, and then the things that are trying to drain into the venous side of the heart, which is the right side, it receives deoxygenated blood from the systemic circulation, will now have a problem dumping blood into that right atrium. Now why? Remember, blood flow will only flow down a gradient. Well, that is a problem because of the equation that we know so well. Venous return equals venous pressure minus right atrial pressure. Remember, we have right-sided concentric hypertrophy. We get a huge bump in pressure of the right side of the heart because the right ventricle gets super non-compliant and thick, and that backs up into the right atrium. Now we have a super high right atrial pressure. What happens when you subtract a very high number from whatever this number is? You get a very low difference, and now there will be no gradient for blood to empty from the systemic vessels, specifically the jugular veins and the hepatic vein. So, when you increase blood backing up into the jugular vein, you get jugular venous distension. And when you get back up into the hepatic veins, then you get hepatic hypertension. So in the liver, there's high hydrostatic pressure. And this is important for two reasons. Number one, because you have decreased drainage of the hepatic portal vein. Number two, you get nutmeg liver, which is just a hypercongested liver. Nutmeg liver is the gross appearance of a congested liver because the hydrostatic pressure causes blood to leak into the sinusoids. It is like the liver is bleeding into the spaces around the engorged hepatic veins. So, a nutmeg liver is classically defined as yellow because the areas surrounding these engorged elements have fat deposits in addition to normal-looking hepatocytes. And chronic congestion can induce a fibrotic response by the stellate cells that are present in the sinusoids. That means we deposit collagen all day until eventually the extending areas of fibrosis from adjacent hepatocytes eventually bridge with the adjacent hepatic venules, making rings of fibrosis around these spared portal regions. This is not the same as cirrhosis from a non-cardiac origin because the fibrosis tends to link adjacent portal areas. This is incredibly high yield. You have to know heart failure backwards and forwards. Now, let's move on to another incredibly high yield topic, bacterial endocarditis. So, it tells you exactly what the underlying problem is. It is a bacterial problem. Some sort of bacteria has invaded or colonized the heart and caused inflammation, hence itis, right? Now, your first aid book lists an acute and subacute endocarditis. Why would we do that? Do we want to complicate things? Probably. But there is a difference in severity and rate of progression. Obviously, acute endocarditis is an acute problem. It happens immediately. So this is probably a bigger problem. Bigger problem usually come from highly virulent organisms. That makes sense why Staphylococcus aureus is the culprit in most acute endocarditis cases. It is a highly virulent weapon in the bacteria world. It is able to do so many things because it has a lot of virulent factors. What are they? It has hyaluronidase. This is a great microbiology review, by the way, so this is why we need to really remember these things. Because I can tie in my microbiology with my cardiology and then ask you a question that makes you uncomfortable because you have to remember a lot of things. Now, what does hyaluronidase do? Well, the ACE lets you know that it probably breaks something down. Hyaluronic acid. So, this is an enzyme produced by Staph aureus that breaks down hyaluronic acid. Hyaluronic acid is highly expressed in the heart, particularly on the heart valves. Another important enzyme released by Staph aureus is leukocidin, and this causes direct endothelial cell necrosis. So this name is important because cidin tells us something. It is Greek for kill, and leuko means white. So originally this toxin was discovered as the agent responsible for killing white blood cells. And the way it works is that it puts pores into the membranes of host cells. This was originally discovered when they did experiments on leukocytes, which is why they named it leukocidin. Now, how does the breakdown of hyaluronic acid, lysis of endothelial cells, and adherence of the organism to the endocardial surface cause vegetations? These are the classic vegetations people talk about when they talk about endocarditis. Now, pretty simple, really, when you consider what is stored within the endothelial cells that we just said leukocidin destroyed. So remember, this toxin destroys our endothelial cells, and what is within the Weibel-Palade bodies of our endothelial cells? Von Willebrand factor and the factor it carries, which is factor VIII. So think about this. Endothelial cells line the heart valves. If you damage the endothelial cells and release these pro-coagulative factors, what's going to happen? Coagulation. So remember, factor VIII is the only factor not produced by hepatocytes. It is produced by endothelial cells. When you damage the endothelial cells, you liberate von Willebrand factor, initiating the formation of a platelet plug. And when you liberate clotting factor VIII, it sets off the clotting cascade. So these vegetations are essentially conglomerates of platelet plugs, clotting cascade elements, and platelets and fibrin. And of course, Staph aureus. Now, another fun fact related to fibrin here is that Staph aureus carries its own coagulase. So, Staph aureus has coagulase, and now what does coagulase do? It converts fibrinogen into fibrin. Why is that beneficial? Well, if you have a bunch of fibrin, it coats Staph aureus with fibrin molecules, and it makes it very hard for antibodies to opsonize or stick to the Staph aureus, and this helps it further elude phagocytosis. I mean, how bad of a bug is this thing? It is just causing lots of problems. It is responsible for acute bacterial endocarditis because it's highly virulent and has a sneaky game plan to evade our immune system. Now, we have this vegetation here that is composed of fibrin, Staph aureus, some of the clotting factors, and clearly it's not something that's normal. We do not want this on the heart. We're looking at autopsy for a reason. This is a really bad situation because we have a pro-coagulative vegetation sitting on an area of high turbulence. So when blood flows over these vegetations, all it takes is just a little bit of force to knock one of these loose, and then we just start throwing little vegetations everywhere. We have liberated one of the vegetations, and you just sent off a brand new ship driven by the captain, Staph aureus, on its new voyage. So that's the analogy for you to visualize that there's now movement of things from the heart valves in the form of septic emboli. So we're throwing around septic emboli of Staph aureus. Where is this newly liberated conglomerate of fibrin, platelets, and Staph aureus going to go? wherever the blood takes it. These septic emboli will travel throughout the bloodstream until they lodge into a vessel with a very small diameter where they get stuck. Now, anywhere these little ships or emboli of Staph aureus land gives the Staph aureus a new location for colonization and infection, and it can potentially cause an abscess as well. So let's talk about some specific locations where these septic emboli can land and how we can see them clinically. So, this is where you need to zone in. This is part of your first aid book. It's listed in there. You have to know it backwards, forwards, all day, every day. Highly important. Gotta know this. Even though I've forgotten it many times, I have to relearn it because I always get asked about it. So these septic emboli can lodge in the retinal artery and vessels. This causes exudative, edematous, hemorrhagic lesions called Roth's spots. It can also go to the fingers, resulting in painful, purple nodules, which we call Osler's nodes. It can go to the arterioles of the nail bed, causing what? Splinter hemorrhages, which are demonstrated in this image.